Hello, everybody. Welcome to the Healing Arts Podcast. I just had such a phenomenal conversation with Jennifer Green-Decker. She is a midwife, and we talked all about midwifery, pregnancy, the birthing process, and a little bit about postpartum care. And my goodness, what an education that was for me. I thought I knew something about this world because of all of the education that I've had, which I have had quite a lot of it, but it seems like when I talk to people like her, my mind is blown and I realize actually how little I know. So this was really a genuine education for me, and I learned so many things. So I invite you to come along with me to learn along with me. If you are either wanting to get pregnant or are currently pregnant or are just curious about this world, this is a great resource, and so come along for the ride. Thank you very much. And this is just loose, just kind of questions that I'm curious about. You know, I want to learn about this too. So
sure.
These are all very, very genuine questions. Yeah, all very genuine questions. There's nothing in here that I'm asking you about that I already know, actually.
Nice.
So yeah.
Awesome.
So a lot of this is really just for me, you know, to learn.
Yeah.
And then might as well share it while I learn.
Yeah.
While I learn, might as well share, because if I don't know, then other people don't know either, right?
Yeah.
So yeah. All right, cool. So Jennifer, yes. My first question always I like to ask is how you got to where you got. Like what has been your journey to become a midwife?
Sure. Yeah. I'm like, that's a long story, but long story.
Please give it to me. I love the long versions, and that's why, you know, there's no time limit on this, and so I really actually like the long versions a lot. So please, if you don't mind, I'd love to hear the long version. How did you get to where you got?
Okay. So I when I was pregnant with my first baby, I started to think about how birth works in like this country or anywhere. I mean, most civilized countries, honestly. And so started to kind of question, because that didn't really make sense to me. I had a lot of fear of like needing surgery, of kind of going down what I would call like the normal medical route. And so I started doing research on that. So that led me, like, started reading Bradley method, and that's not quite as popular as it used to be. So my oldest is 21. So this was, you know, a minute ago. And so I was just looking for other options. I didn't really know anybody who was having even natural births, like, not to mention like out of hospital births. So I was just looking for somebody or for something that made more sense to me. So started doing research on that, found the Bradley method, and the Bradley method is basically like encouraging women to like breathe slowly through contractions and stay perfectly still. And like really it's more about your like using your mind to like, it's not really hypnotize yourself, but in a way. So focusing on that like natural breathing, but you're like really releasing your body so that it can do whatever it wants to do.
Cool.
Yeah. And Dr. Robert Bradley was like the founder of that. I read his long textbook, very boring, dry material. And then I read the more like, you know, broken down version, and then used that to practice. So, and it worked for me. So
in your own pregnancy and in your own birth.
Yeah. So I had a 30-hour labor, and I did find like the only midwives in town. I called the hospital and said, do you have any midwives that deliver here? And they said no. And then I talked to other like women in the area, and somebody was like, we do have midwives. And so found
they just didn't know of any.
I guess the receptionist didn't know.
I see.
But they did deliver in the hospital. So I was in Nebraska. Home birth midwifery is still illegal in Nebraska.
Illegal?
Illegal, yes. You're not allowed to attend births at home.
Okay.
So it's never illegal for a woman to have her baby wherever she wants to have her baby.
Okay.
Because that's like a human right. But it is illegal for people to come and attend that as a medical professional. I know. Unreal.
That sounds crazy to me.
Yeah, so it was. And I wasn't really considering a home birth at that point. Like, I just wanted to avoid surgery. That was like my biggest thing. I was like, no, like, I'm healthy. I've never had any medical problems. Like, if I got pregnant, I should be able to birth my baby.
Yeah.
Like, that's all. And so when I found a philosophy that aligned with that, I was like, great, I'm going to try to do this.
Goodness.
And so I did, and my midwives told me stay at home as long as possible. And I was like, okay, bet, I'm on it. And so I did. I stayed at home for a very long time. And my husband at the time, I was like, we were 30 hours is a long time. My mom flew into town, like everything was going on. So my mom had time to get there, and then she it kind of like piddled out. Everybody kind of looked at me, so I labored like all night long. And in the morning, it kind of like, I was still having contractions, but they were very mild. And everyone's kind of looking at me like, where did labor go? And I'm like, I don't know. So we went out to breakfast, we like hung out, watched a movie, and then it came back. And so I tried to go to bed again. I talked to the midwives. They were like, try to get some sleep. I was like, okay.
Huh.
And so laid down for like a few hours and then woke up in like rocking labor. And so I was laying on the couch and I was like, look, if it gets much worse than this, I don't think I'm going to be able to like be pleasant when they're trying to give me an IV and stuff. Like this is pretty hard. And they were supposed to give me an IV like for GBS. That's a long story, but group beta strep. So it's a bacteria that can live in the vaginal tract. I had tested positive, and it can cause respiratory issues for newborns. Nobody kind of gave me options like, do you want antibiotics for this, or like what are the pros and cons, what are the risk factors? I didn't really get that. It was just kind of like, come in about 4 hours before you deliver, we're going to give you an IV and with antibiotics.
Huh.
And I was like, okay. So I was finally told my husband at the time, I think I'm ready to go. Like, they're going to have to give me an IV. I don't want to be like fighting people or like getting upset. So, because doing contractions and anything else is pretty difficult, as you can imagine. So he was like, well, I have no gas in the car. And I was like, in the last 28 hours, at no point were you like, maybe I should make sure I have gas in the car. And we lived like 30 minutes from the hospital, like across town. So like stop and go traffic, 30 minutes. And so I was like, oh, and he's like, it's okay. I'm going to go get gas in the car. I'll warm the car up because it's very cold. It's January in Omaha and it's so cold. And so I was like, okay. And then we did the horrible ride to the hospital. So it was just really long. It's very hard to sit in a seat. Yeah. If someone needs to go to the hospital, I'm like, one, don't. But also, if you need to go to the hospital, like just kneel in the back seat. Don't try to sit in the passenger seat.
Facing backwards?
Yeah. Exactly. Because sitting when there's like a baby trying to enter your pelvis is very uncomfortable.
Okay.
Yeah. So all that to say, we get there and I'm like basically complete and push the baby out. So it was like, great. Super happy about all of that. It was like a good experience. Postpartum was really hard. So they wake you up a lot. They wake the baby up a lot. They do a lot of things that aren't really helpful. And so you're kind of sleep deprived, exhausted, and feel totally incompetent by the time you get home. So that was really rough.
And their reasoning behind that is they want to keep tabs and like keep track and make sure everything is okay. Is that what they would say is their reasoning?
There's a lot of liability around newborns.
Okay.
That's what I would say is like the purpose, is that where they are fragile, especially some newborns, I would say full term newborns are not that fragile as we think, but we do act like they're fragile. And I think that might be because of the liability around newborns. They're just not, there are some hospitals that are good at supporting physiological birth. I haven't yet to see a hospital that is good at supporting a physiological postpartum period. They don't treat mom and baby like a unit. They treat them like two separate patients. Like there's just a lot of reasons that is the way it is. And then there's too much intervention. So we need to learn how to do less with moms and newborns. We need to learn how to just let them be together and move on. They don't let you can't hold your baby and sleep in the hospital because they're scared they're going to drop your baby.
Oh, come on.
Yeah. And it's very hard for a new mom to sleep when they're not touching their baby. If I wasn't holding my baby, I couldn't sleep.
Yeah.
Like literally, I was like kept trying to like lay him down and go to sleep, and I could not sleep. So I'm like, I can't sleep because I don't know if he's okay.
Yes.
And so, of course, like biologically, this makes so much sense. Like you were attached literally for 9 months. So you take the baby and put them over there. Like the baby's scared and you're scared. So it's just not, it's a setup for a disaster. So, all that to say why I got into this. So like my second baby, I was pregnant. I kind of knew I could do this naturally. I had moved to Colorado, and my mom actually had me at home. So I just thought she was kind of crazy. So I was like, she was a hippie. She was like a Woodstocker. Like she was like all hippie. So I was like, of course you have me at home. Like you're a hippie. And so, but she had me at home, and I was like, maybe I should just do that. And it was because of the postpartum. I was like, I want to just do this, have my baby, and go to sleep. Most babies will take a post-birth sleep of up to 6 hours. And I was like, that's what I needed. I needed everybody to leave us alone. Yes. Like I just pushed my baby out. Yes. We fed him. Let's just go to sleep. Yes. And then we'll wake up and we'll do all the newborn things. Yes. And so, literally that's what I do now, right? Is like help that happen for people. So that's what I did. I hired a home birth midwife. I really thought at this point, I was thinking there's nothing magical that happens in a 10-minute visit at the doctor's office that's keeping me and my baby healthy. I've known women that have lost babies at 38 weeks with full prenatal care, and I've known people with no prenatal care that had healthy deliveries. So I was like, what's making my delivery healthy is me taking care of myself. Like eating well, like moving my body, tuning into what I need. That's what is carrying this pregnancy. Yes. You know, not this little like 5 minutes, listen, check your cervix. Like that's not it. Yes. And so I wasn't quite as scared of home birth as I was the first time. I thought, this is going to happen wherever it happens at this point in my life. And so I did. I had my second at home. It was very fast. It was like a 2-hour labor, no big deal. Yeah. And then I went to sleep with my baby, and I was like, this is fantastic. Night and day difference. My recovery postpartum was so much better because I had that time to just like come down off of all the adrenaline of labor. So yeah, I always said I knew after my first I wanted to get into birth work because I realized that there were just so many lies that I had been told about birth. Like I thought it was going to be exceedingly painful. I was really thinking at some point I'm going to be screaming. Like that's how it's going to be pain wise. Like this is going to be like I got into a car accident. I'm having surgery with no anesthetic. Like I'm, inconsolably upset. Right? Yes. And that was not my experience. Like I wasn't screaming. I wasn't, yeah, it hurt. I'm not going to tell you like labor is easy or it doesn't hurt, but it's doable in a way I didn't understand. There's not pain in between contractions. And I'm going to say things, these are things that are true for me and for most women. And like, there's no real rules in labor and birth, and somebody's going to be out there who's going to be like, I had pain all between my contractions. Yes, that can happen. So, okay. And that's why we have epidurals. Like these are tools and they're okay to use when we need them. But for me, I felt like I really loved being part of the process, and I really felt empowered by that, felt more bonded to my baby. I felt more like competent as a parent. It kind of gave me a faith and like appreciation for my body that I hadn't had before. And so I thought people are missing this. Like we're signing up for like a way out of the pain, but in that we're missing something bigger. Yes. And so I was like, we can do this and people need to know. So I just started telling all my friends and started like doing doula work, but I didn't really know about doulas yet, but going to births with my friends and like rubbing their back and saying like, you're doing amazing and this is exactly how it should be. And you've got this. And you've got this. But I really liked sleeping at night, obviously. So like a lot of my decisions revolved around how much sleep I could get. So I was like, I don't think I could go into birth work because I don't know if I could be awake like through the night regularly. But then I had a third kid and I was like, I'm not really sleeping anyway.
Sleeping anyway.
Yeah.
Oh, that's funny.
Yeah, so that's when I decided to pursue birth work, and it just felt like a huge like calling on my life. Like I felt a lot of urgency. Like as soon as right after he was born, I was like, I'm missing something. I'm supposed to be doing something else, and I'm not sure what that is, but I need to figure it out. And just like really intensely for several weeks. So yeah.
Amazing. I think it's really great whenever you're called into something based off of your own experience.
Yeah.
Rather than like I'm a chiropractor, but I actually didn't really get into chiropractic because of something that I had that a chiropractor like fixed for me.
Yeah.
You know, but I always feel like it's maybe more powerful for people who like, you know, I have many friends who got into the work that they got into because they themselves had an experience, you know, and so
yeah.
What I mean to say is that I think that's great that you got
sure.
into what you got because of your own experience. So that's cool. I have so many questions based off of everything that you just said. I hope I'm able to remember all of them because that's great. Okay, so maybe the first question I could ask based off of that is these laws, first of all, seem crazy.
Yeah.
Like hospital laws. Are those state by state? Or is that like
whether you're allowed to birth at home?
Whether you're allowed to do all kinds of things that you said you have to or you're not allowed to or whatever in Nebraska.
Yeah.
Is that like a nationwide thing or is that like a Nebraska thing?
It's a Nebraska thing. So it's state by state. There are still states where like home birth, or some people call like lay midwifery or direct entry midwifery, is not legal. And so the kind of midwife that I am is I'm not a nurse practitioner. So I got into midwifery directly, if that makes sense. So I do have an undergrad degree. It's in like counseling, marriage therapy.
Okay.
But I didn't, when I decided I wanted to be a midwife, I didn't decide to like pursue becoming a nurse. There's a lot of reasons for that. In my opinion, I'm like, this is like the medical model versus the midwifery model. And so becoming an RN is definitely part of the ladder to be part of the medical system. And so I didn't really have an interest in that. And I went to school for like counseling and therapy. And then by the time I got through it, I was like, I actually don't want to work in that system. I was like, that doesn't seem effective. It doesn't seem like you have enough like freedom. It seems like you're going to get all of these degrees, but at the end of the day, you're just part of the rat race. And that didn't really like call to me. I was like, so I was a little worried of that happening with midwifery because I was like, I don't really want to lose this calling. Like I know what I want to do. So what if I just do it? If that makes sense. Because as a CPM, you can enter like an apprenticeship. And I did an apprenticeship for like 6.5 years.
CPM? What is CPM?
So a CPM is a certified professional midwife.
Okay.
So nationally, that's like kind of what we call ourselves.
Okay.
Yeah. And it is like a credential that you have to like earn. And it takes a lot of clinic hours, and there's an 8-hour proctored exam, and it's a whole process. And I would say it's equivocal to getting a bachelor's degree, but a lot of it's just hands-on. Like you're working like an architect or like where you're like on the job. And so I worked with a experienced midwife for 4 years, and then I started working with my friend who I still work with now when I was kind of ready to do my under supervision, or like primary under supervision phase is what they call it.
And so these are like midwifery schools, like not university.
So there are midwifery schools. I did like self-study. So it's called the PET process. It's like a portfolio evaluation process.
Oh, that's cool. And then you test out.
Yeah.
You study yourself and then you test out through this organization.
Yeah.
Okay.
Yeah, but there are MEAC accredited schools, and you can take a 4-year program too.
Okay.
If you want to do that.
That's cool.
Yeah.
Cool. Right on.
Yeah.
Okay, so do you know of any states, well, before I ask that question, how is Colorado as far as freedom goes through hospital systems to do what you want to do?
Yeah.
How free is Colorado?
I mean, I feel like Colorado is pretty like home birth midwifery supportive.
Okay.
On average, there's a couple states that are better.
Which ones are those?
Washington, Oregon.
Makes sense.
I just say better because they're more like home birth midwives can do breeches and twins, and with good informed consent. And so, like, there's regulations here, and there's pros and cons on how we are regulated right now. So we're not regulated under the hospital system. We're regulated under DORA. And you're probably familiar with DORA, like as a chiropractor. Exactly. So we have, and then the person who oversees our section in DORA is usually pretty ignorant of what we do. They're pretty ignorant of what practice looks like. Usually it's kind of like us and the pharmacist lumped together. They don't really know where to put us.
Huh.
So that can cause problems.
Also maybe a little bit more freedom, maybe a little
sometimes,
little less
yeah,
stringent.
Yeah,
maybe?
So it would be nice if I believe it would be nice if we could be reviewed by a board. If an issue comes up, there was like a board of people who were doing what I'm doing who could say, yes, that was reasonable or not. That's not the process. We have like specific regulations, which feels a little bit constrictive, if that makes sense. It's it's very specific. Our regulations are very specific. Even as far as like how long can their water be broken? How long can we push? How long can we... It's very specific. In my opinion, too specific. I'm like... Because things change all the time and evidence changes all the time. And so it's often outdated.
I see.
And I'm usually telling people what I'm supposed to do at this point is this, and would you like me to do that, or would you like to decline that? And so I'm always kind of walking that line between their patient autonomy, which according to the law, I should always be able to respect, and my own regulations.
Okay.
So that's a hard line sometimes, because there are people that would like to have a breech baby at home. That would be a good candidate for a breech home birth. But even if they say they want to do that, doesn't mean I'm allowed to do it.
I see. So there are certain things that you're able to sort of finagle and certain things that you're not able to.
Right.
I
Less
see.
so. Mm-hmm.
I see. Okay.
Yeah.
So why is breech at home such a problem?
It's not. It's literally not.
Okay, so then why
ask him that.
why do they say that it's a problem then? Like what would be their
the thing is that vaginal breech birth is not the standard of practice, period, anywhere in the US.
Sure.
Does that make sense? So
sure.
Why would they think it would be okay at home? They've not been trained in breeches for years and years and years. I mean, OBs stopped being trained in breeches. So they might have like...
They just C-section
they might have a chapter on it, but they're not comfortable practicing breech birth, by and large, in the hospitals in the US. So why would they think it would be safe to do at home? Does that make sense?
I see.
Mm-hmm.
I see. Okay. All right.
They're worried the baby won't come out.
They're worried the baby won't come out, like a shoulder will get stuck or something, or...
Yeah, so head entrapment is like a big concern. The baby comes out and the head doesn't come out. There are ways to fix that.
But there are ways to fix that. Mm-hmm. If only you could learn about it and are able to practice it, then it wouldn't be as big of a deal as people make it out to be.
Right. And especially if we've had a baby before, if this is not the first time she's birthed a baby, if we've had a different baby 2 years ago, the baby is going to just come right out. This is a non-issue.
Wow.
But
I've never heard someone be so nonchalant and confident about that before.
Yeah, well...
That's pretty cool.
Yeah, I mean, I've been through a few trainings in breeches. I, caught a couple surprise breeches, so... But they do come out.
They come out. You just have to know how to manage it.
You need to know how to manage it if it needs to be managed.
And sometimes it might even not need to be managed.
Exactly.
Sometimes
most of the time, it doesn't need to be managed.
This is such a different perspective.
Just because the head's not coming first doesn't mean it's not going to come out. Yeah. But.
Okay. So maybe sometimes there can be some issues, and you just have to know how to manage it.
Yeah.
And otherwise, people might be surprised at how much of a non-issue it is.
Right.
That's very cool.
So we've shown, there's been some studies on breech births, and Dr. David Hayes is a really good resource for breech birth. He does Breech Without Borders with Rixa. I can't remember Rixa's last name. Freeze, maybe? And so they have a whole book and compilation of studies, and then they've kind of broken down some studies that have been used to stop vaginal breaches in America, basically. They've kind of combed through them and explained why those weren't really full, they weren't really correct. But basically, we do know, if we do a breech birth for this baby, like a vaginal breech birth, we know that there's more risk to this baby. But we know that for the mom and any future babies, we're lowering the risk. Does that make sense? Because we're avoiding surgery. So we know that the safest way for this baby to come out is probably going to be a cesarean. And I will tell people that the safest method for this baby to be born is a cesarean. I know nothing bad's going to happen to your baby. But then you have a uterine scar.
Right.
And so that uterine scar means that any subsequent babies are going to be more at risk for having placental issues, for having repeat surgery, which endangers mom's life, or having just like all kinds of issues.
Huh.
So.
See, and that's something that from what I have learned in my little bit of pregnancy education, is that VBAC, as they call it, vaginal birth after cesarean, is not as big of a deal as people make it out to be.
Right.
Like ladies can do it. And you can be confident that you can do it. So what's your opinion?
I agree.
You agree.
Yeah,
however, the risk is increased.
Absolutely.
Okay.
Yeah.
Okay. Risk is increased, but that doesn't mean that it's not possible. You can still do it. You just have to be more careful or something.
Yeah.
I see.
Basically. And then it depends on how many times you've had surgery. So there's a big difference between having a VBAC after one cesarean or having a VBAC after 2 or 3 cesareans. You know, because you're going to be at greater risk of like placental abruption, uterine rupture, things like that, which sound really scary. They are scary. I mean, they are, honestly. I mean, placenta abruption is very scary. Basically, is when the placenta like leaves the wall of the uterus before the baby's born, which is obviously an emergency.
That's not good.
It's not good, and at least it's a problem, and that the mom is bleeding.
Yes.
So I did help somebody have, she was trying to do a VBAC after 3 cesareans. I was like, we're not going to do that at home because I don't know like how it's going to go. But she started care with Denver Health, and they have like a group of midwives that were super supportive for her. And during her labor, she had an abruption. And so the baby still sounded fine. So enough of the placenta was attached that the baby was still getting good blood flow, but mom was bleeding.
I see. Mm-hmm. So then do they go in there and like cauterize, like a surgeon cauterizes, or how do they?
So they just have to deliver the baby. I mean, she had to have surgery again, which sucked, but
I see.
It's like, well, you tried everything you could try, and this is not actually safe for you.
Yeah.
Like
they just C-section it and then call it a day.
Yeah. And so once the placenta is out, and the baby is out, the uterus can involute or like shrink down to how it's supposed to, and that kind of like seals off the wound. So that's how the body stops bleeding from the placenta. Is like it has to be empty.
Oh wow, that's cool. It shrinks itself down and closes off. Oh wow, that's cool.
Exactly.
Oh wow.
So it just, and then.
Interesting.
Yeah, she was fine. She didn't bleed too much after that. And just like, she was only 4 centimeters. I'm like, well, yeah. I mean, I felt really bad for her. She was really heartbroken.
Yeah.
She really wanted, I was really grateful we were in the hospital.
But also, a healthy baby is more important than the pride of, I had a VBAC after 3.
Yeah. You know? Well, I don't think it's, like, I don't want to minimize, like, what she wanted, because for her, it wasn't really, like, the pride of giving birth vaginally. It was more, like, feeling like she had been, like, suffered a lot of trauma with her cesareans.
I see.
Does that make sense? Like, she felt like she didn't have the chance or support, or, like, nobody was really, like, supporting her trying to have her babies vaginally.
I see.
And so for her to give up that dream, it was really hard. It was, we had a come to Jesus moment, like, in the labor. And I was like, I know this isn't what you want, but there's no way for this baby to come safely. Like, this is the only answer. You've tried everything you could. She's such a good girl. What happened, actually, crazy, because she tends to carry breeches. Speaking of breeches, and a couple of her cesareans had been for breeches. And at Denver Health, they were willing to do a vaginal breech VBAC after 3 cesareans. Huge, right? That's cool. I know. The doc was like, I don't recommend it. This is dangerous, but very respectful about it. Not at all like browbeating, like, not barraging her. And so that was like awesome. And we were kind of talking to her baby all through the pregnancy. Just ask her to go head down. This will just make it a lot easier. Just ask her to go head down, ask her to go head down. And then she did flip, like the day before she went into labor.
One day,
yeah. She flipped and then she went into labor. And her labor started with like a big gush of bleeding.
Oh.
And and then it kind of stopped. So we were like, okay, maybe we're okay. But I just felt so sad. I feel like that little baby was like trying to be such a good girl, and she was like, you asked me to flip, Mom, so I'm flipping. And I just think she had a short cord, or it was wrapped funny, and it just pulled on that placenta too much. She was like, I wasn't supposed to flip. I can't. So sometimes I tell people, like, sometimes there's a reason that babies are breech. So, ask them, but if they don't turn, like, just leave them alone. Sometimes they need to be breech.
Yes.
Rather deal with a breech than an abruption any day of the week.
Or a cord around the neck or something.
Oh,
Sometimes I wonder about that. Tell me what you think about this. I have a little bit of experience with babies flipping during chiropractic work.
Yeah.
And sometimes I wonder, like, this baby just flipped, but is the cord okay?
Yeah.
Is that... Should that be in my mind? Can I just let that go? Or should I
don't think you should worry about it. I think when you're setting your intention to the baby, it should be with like a air of humility. Does that make sense?
Yes.
So like we would love it. Like if you could move, we would love that. Like that's all, not be like forceful about it or like the best thing for you to do or just as a request, I guess, instead of as, but the cord being around the baby's neck is not a problem. That's like a whole thing.
Tell me about it. How is it a whole thing? Can you unpack that?
There can be cord accidents. And so I think that's what you're talking about when you say like, you get nervous when a baby turns. I feel like with chiropractic, you're really just like making room for the baby to turn.
Yes, that's
and
correct.
Most babies do want to be head down. Their head is the heaviest part of the body. Like it's going to be dragged towards the earth, and they're going to have more room in the bowl of the pelvis for their head to like wiggle around instead of it running into like mom's ribs all day.
Yes.
So I feel like in chiropractic, you're not really turning the baby.
Correct.
You're just making room for the baby to turn.
Correct.
If this baby is very hung up with their cord, they're not going to turn.
They're not going to turn.
Right. They're not going to turn on their own, without that.
Okay.
So there is like an ECV, so like an external cephalic version. So if a baby doesn't turn and a mom gets to 37 weeks and this mom for whatever reason wants to have her baby head down, she can go into the hospital and a doctor can try to manipulate and turn her baby.
Like make that baby.
Literally make the baby turn.
I've heard of these procedures. I've heard they're very heavy-handed about it.
Exactly. And so in that kind of procedure, we're listening constantly to the baby. They try, I've been to one and they stop for 30 seconds at a time, they stop listening, and then they like pour oil on her belly and like flip the baby around. Yeah, like exactly. Like wrench the baby around. And so it was effective when I went. They took him like 20 seconds, the baby flipped, and he stayed there.
Oh wow, 20 seconds.
It's very intense.
That's very short.
20 seconds. They give her terbutaline, which is like a drug to stop contractions. So basically her body wants to protect baby. So if somebody is trying to like shove on your womb, you're going to have like a massive contraction, and your body's going to keep the baby where they are. Like it's going to be like, no, leave us alone. So it's a drug to make that not happen, to allow manipulation. So, but there is a chance that the cord will pull too tightly on the placenta, that when we're really like making baby move, that we're going to cause a cord accident. It can also cause like a rupture of membranes, or like the water is releasing. It can cause cord prolapse, which would be like cord going like in front of baby's head, so which would be a problem.
Cord in front of baby's head.
Exactly. So if the baby gets really down in the pelvis and there's like a cord above the baby's head, it can kind of cut off blood flow from that cord. The baby's head is very hard and the pelvis is very hard.
And that I see the head is like squishing on the cord.
Exactly. And that would be like if the water is released in that position.
Okay.
Because even if it's in front of the baby's head, if you have like this nice sack of water, you're not going to be able to squish it that hard.
Yes.
Yeah.
Okay.
So, but the cord being around the neck is just like a scapegoat like 99% of the time. So
what do you mean by scapegoat?
It's like a thing that we blame for why the birth didn't go how we wanted it to go.
Oh.
So she needed a cesarean. Well, the cord was around the neck.
Oh,
you know,
got it.
The cord is around the neck in about 30 to 35% of babies. Yeah, all the time.
Oh, wow.
Literally,
it's
all the time. It's so common,
oh,
yes.
Wow.
And it's usually not a problem. Most healthy cords are full of Wharton's jelly, which is like I don't know how to explain it. It's like a gel, and it's like very viscous and thick, and it kind of protects those vessels. So there's 3 vessels in the cord, 2 arteries and 1 vein, and that Wharton's jelly protects those vessels from getting compressed. So, and also we're not breathing. So I think when people are thinking about the cord being around the neck, they're thinking the baby's strangling, right? And like you're imagining the baby being like strangled. Right?
Baby's not breathing.
The baby's not breathing, so the baby isn't stopping breathing because the baby has never breathed yet.
Why have I never thought of that? Baby's
Right.
not breathing.
Yes.
Wrapping around the neck, they're not breathing. Why have I never thought of that?
Literally.
Oh God, I feel so
Literally.
silly.
No, it's okay. It's so common.
Baby's not breathing though.
People, that's like a question I still get in consults.
Oh,
what do you
no.
do if the cord is around the neck? I'm like, 90% of the time, nothing.
Nothing.
90% of the time, I don't do anything
So
about
what
it.
would the 10% that you do something be?
If I think it's impeding the birth, then I will unloop it around the baby's head. So, yeah. I'm like, it does not usually impede birth.
Wait,
so
how would you unloop it?
you just pull it and loop it off the baby's head.
But this is after birth you're talking about.
No, like when the baby's head comes out.
Oh.
So if the baby's head comes out and then the shoulders,
okay.
if the shoulders don't come out,
Okay.
and if I think that the baby's cord is causing a problem.
Okay.
Or could cause a problem.
Okay.
Or maybe I'm just like, if we do it now, we don't have to do it when the baby comes out, and I want this baby to breathe as soon as possible. Because now they've been sitting with their head out and their body not for like a minute or 2. Well, that's kind of a long time for a new baby. So,
Yes.
you know.
Yes.
Yeah.
Yes.
Shoulder dystocia is way more of a problem than the cord being wrapped around the neck. And even if it's very tight, it honestly, I don't know, there's just so many things. Honestly, if it's gonna be a problem, I probably won't be able to loop it around the baby's head because that means it's a tight cord. Does that make sense?
Yeah.
So if we have a tight cord,
Yeah.
the solution is not to loop it around the baby's head. In the hospital, they clamp and cut the cord on the perineum. I have tools to do that. I have never needed to do that, thankfully. I don't like to cut the cord before the baby's out. It really causes a depressed baby.
Yes.
When they're in the birth canal, a lot of their oxygenated blood is squeezed out of them back into the placenta because it's a very tight fit, as you can imagine. And so this cord is full of oxygenated blood. Their placenta is full of oxygenated blood.
Yes.
If I clamp and cut that cord on her perineum, the baby loses 30% of their blood volume.
Yes.
So I don't want to do that.
Yes.
Like, why would I do that?
Yes.
So, like, instead, what you can do is kind of manipulate the head towards the perineum or like towards mom's bottom, and then that will allow the shoulder to like slip out. And then you can like leave the cord intact, and then you just unloop it.
Yeah.
Just sometimes it's around the shoulder or the arm or the body or the foot or
And it's all good. There's wiggle room for that cord to do its thing.
exactly. But I don't want to like. You know, like I said, there's no rules. I'm speaking from my experience. I know that there will be people out there that have had a cord accident happen with one of your children, been very scared for their life, or been very scared for, you know, or lost a baby. Like I said, healthy cords are full of Wharton's jelly, but I have seen thin, sickly cords that are more at risk of getting compressed. That blood flow through the cord is very important. So,
And what do you think could cause a thin cord?
a lack of nutrition, not maybe having the blood flow that the placenta needed whenever the placenta attached, which could be like an MTHFR variation. It could be stress. It could be where like previous surgery where this placenta decided to attach, you know, so many things.
Okay, cool. Wow, this is fascinating. This is so fun. Okay, I have one more question that I'm remembering based off of your first kind of thing. You mentioned that, and you tell me if I heard this wrong, but I think I heard you say that people don't need to go to hospitals for births.
Yeah.
That's a big statement.
I wouldn't say nobody needs to go to the hospital for birth.
Okay. So in what circumstances would you recommend someone go to a hospital?
Yeah, that's a great question. If you have another like serious health condition, say part of your body does not work well, your lungs, your heart, your I'm trying to think what else, brain, like if you have seizures, if you have if you're type 1 diabetic, if you have major health issues, you should deliver in the hospital.
Okay.
100%. You're going to need all of the intervention to keep you and baby safe.
Okay.
You know, yeah, that sucks, but find a hospital that can do those things for you and give you some freedom in those choices, you know?
Yes.
Yeah, absolutely. And then there are always things that can come up like during pregnancy or even during labor or birth, you know, and that would be like, well, there's like a myriad of things. During pregnancy, like if someone got preeclampsia, I've taken somebody into the hospital at 38 weeks because she got pretty raging preeclampsia. High blood pressure, headache, you know, swelling, the whole thing. And we were not in labor or close to labor. So I'm like, I'm not going to be, and it was her first baby. So I'm like, well, I'm not going to be able to get you all the way through labor and keep you from having a stroke, basically.
So the danger of preeclampsia is stroking out.
Among other things.
Among other things.
Yeah. So preeclampsia affects a lot of body systems. So if it's untreated and we don't deliver a baby, your liver is in danger, your kidneys are in danger, but also, yes, stroke risk. And at the worst, like DIC. So.
What is DIC?
Disseminated intravecular. I don't know. It's you like internal bleeding. You run out of platelets is what happens.
Sure. So a hemorrhage.
Yeah, but it's not from bleeding. It's like from your body attacking itself.
Oh.
Yeah.
Oh.
Yeah.
Oh.
So that's like HELP syndrome. So, I'm like, what does HELP stand for?
Yeah, I don't know that either.
I'm like, I do, but I forgot. It's like, but the last one is high enzymes, low platelets. I don't know. I'll get back to you.
Okay. Okay, cool.
It's basically like severe preeclampsia.
Got it.
But HELP syndrome can come on without preeclampsia.
Okay. And then what would be some warning signs of preeclampsia? You mentioned swelling and headache.
Yeah.
Like maybe like wrist and ankle swelling.
Yeah, so usually we say all over swelling.
All over swelling.
Yeah,
Okay.
not always, and that's the thing about preeclampsia. It does usually make you feel like crap. So you usually feel like general malaise, and you can have epigastric pain up in your upper abdomen, kidney pain like along your back, your liver can ache, headache, high blood pressure, spilling protein in your urine. You usually feel pretty crappy.
You just feel crappy, and then an easy way to verify would be to take a blood pressure reading.
Yep.
And then
absolutely.
And then what would be a threshold number that you say if it's above this, then we need to go to a hospital now? Is that
so ideally you want your blood pressure to be under 140/90, and both of those numbers should be under that. Does it make sense? So even one or the other is still kind of a warning sign.
Okay.
But treatable was 160/110 here in the Springs. I don't know if that's like everywhere, but basically that means that if you go in, if one of them's over 160, if your systolic is over 160 and your diastolic is or your diastolic is over 110, they're going to treat it immediately. So they're going to give you hypertensive medication. In labor, that usually looks like magnesium sulfate on an IV drip, but there's options. And it depends on the provider.
Okay, and under a preeclampsia situation, is the correct approach to go to the hospital right away? Or not necessarily? Does it depend on how far you are?
Yeah, I think it would work with your provider.
Work with the provider.
Yeah.
Okay.
Because, what needs to happen is we need to do labs. So if we're kind of on the border of 140/90, blood pressure, changes like minute to minute. So we're not going to get one reading and then be like, okay, straight to the hospital. To be diagnostic for preeclampsia means you have two blood pressures over 140/90, at least 4 hours apart, and proteinuria. And you're spilling protein in your urine.
I see.
So we really need a 24-hour protein catch, and we need to draw labs and see how your kidneys and liver are doing.
I see.
So that's what needs to happen.
Got it.
So, and then it depends. Like if you're 39.5 weeks and this is your second baby and you had one high blood pressure, like maybe you could just have the baby.
Yeah. Go go do some nice slow breathing, light a candle, and
right.
get a massage and relax. Kind of thing.
So and then there's also what's called pregnancy-induced hypertension. So some women kind of have creeping high blood pressure because of pregnancy. So that's the point of the lab work, is to try to differentiate. Is this preeclampsia, which can be very serious, or is this pregnancy-induced hypertension?
Interesting.
Which is less serious.
Interesting.
Yeah.
Interesting. Very cool. Very cool. Okay.
Yeah. But definitely let your provider know and say like, hey, this is going on.
Yes.
What should I do?
Yes, yes. Okay. What is the difference between a doula and a midwife?
Yeah.
Is it like AKA, or is there a difference?
No, there's a difference. So doulas are not medical providers. So a doula is like a non-medical labor support. And so they usually do a few prenatals, but to kind of like educate you, prepare you, find out like what kind of support that you're needing during your birth process, and then they attend the birth with you. But they're doing things like massage, aromatherapy, like educational support, talking you through their options. They can help you advocate for yourself. I know doulas are often like pitched as like birth advocates, and I know that a lot of doulas do have like a passion for birth advocacy. In most hospital settings, your doula cannot speak for you. When somebody asks you a question, you or your partner are going to need to answer the question. So that's why I say more, I think their job is really more like education and preparing you for that, and like how to ask for a minute. Like you can totally say like, hey, I'd like to talk this over with my partner and my doula, and like, can you give us a minute? And then we can like all talk about it. But
cool.
Yeah.
Cool. Maybe like more moral support. Doula, maybe a little more moral support.
Yeah, for sure.
Midwife, more direct.
Yeah, so we just have different like roles during the birth process. Like I'm not a great doula. Like I don't like to be in the hospital setting, but doulas are helpful in every setting for sure. But they're also they're just like the hands-on support, and a lot of doulas are very skilled with like spinning babies and trying to help baby navigate the pelvis in like the most efficient way, getting mom in different positions. Also, most doulas will attend the birth from early labor until the baby's born, and like I'm not gonna come until we're like pretty active, because my role is more like the medical side of things. So midwives, we say we're like the guardians of normal birth. Like it's my job to make sure your vitals are okay, baby's vitals are okay. Like we are attending to risk factors that have to do with you and baby medically. Does that make sense? So I'm listening to the baby. I'm doing cervical exams if we need to, if we need an IV, I'm assessing that, like discussing it. Like we're doing all of those like provider things.
Gotcha.
At the birth. And then most of what midwives do happens after the birth. After the birth, the doula is kind of done. Like they're like, okay, great, you did it. And they hang out, maybe help with breastfeeding a little, and then they're like, I'm going to go home and take a nap. Great. But most of what we do happens after the birth.
After?
Yeah.
What?
Yeah, because really, like the mom is doing the work of labor.
I see.
So as long as nothing's going wrong, and usually nothing goes wrong, then we're just kind of watching and waiting and like, assessing every once in a while. But then the baby comes out, and then we're like making sure baby's breathing, make sure baby's warm, make sure she's not losing too much blood, help get her out of the tub if she's in the tub, helping the placenta come, all those things, breathing for the baby, like doing, all of that stuff if we need to. And then we do suturing and like make sure like everything's all, fixed up before we go. We do a full newborn exam. We like get baby mom up to pee, shower, feed her. We're doing all the things in the first couple hours after birth. Yeah.
I don't know why I didn't know that.
yeah, because it feels like, well, you're in labor and then the baby comes out and we're all done. But not for us. Like that's when our team is like doing the things more. Wow. Okay. How often do you have to suture? How often is there a tear?
I
would say more often in first-time moms. So I would say in first-time moms, maybe 50% of the time.
Whoa, that's a higher number than I was hoping to hear.
Yeah. And most of them are just like 2nd-degree tears and like not serious, but they will heal better and they'll heal more together with less scar tissue if we approximate the tissue. So in mole tips or people that have had babies before, not very often. Like 15% of the time.
Okay.
20% maybe.
Okay.
On a bad month, I guess. Yeah.
Wow. And the tears, do they always go posterior towards perineum?
They do not always go. Yeah, they do not always go That would be really nice of them if they could just always go posterior. The perineum is a great place to tear. Very muscular. Very well circulated with blood.
Yes.
Yeah. So the perineum heals much better than the vulva. It's not so forgiving.
I see.
Yeah.
I see. Wow. Oh my goodness. Okay.
But yeah, most often it's down.
Most often it's posterior.
Yeah.
Okay, cool. So
we encourage moms to reach down and birth the baby into your hand. Yeah, so if mom can kind of connect with the process, then she usually does a good job of protecting her tissues. Yeah.
And by birthing into your hand, do you mean holding the head and kind of guiding?
Yeah. Or some moms put pressure up top to help the baby not tear up, to more tear down. Yeah. Whatever feels better to you, whatever feels like it's helping.
Yes.
Do that.
Yes.
Yeah, we used to do a lot of guarding the perineum, and we don't do that now. Because I would rather you tear down.
Tearing down is better.
Yeah,
and tear down.
100%. Also, all that massaging and supporting, and it doesn't help. So we've learned over the years and through studies, it doesn't actually help. So it might feel better, but it's not helping. We're actually swelling the area and making it more friable.
Okay. So connecting with the process, I have a question about that. I have a friend a dear friend who got an epidural. So she was contracting, everything was going, and then she got an epidural and the whole process stopped. The contractions stopped, everything stopped.
Yeah, that's very common.
That's kind of the point in a way, is to paralyze, block. Yeah. So if you're gonna block, then of course
the epidural
surprised.
Relaxes your whole lower half of your body. So. And
I would say turns off the lower half, right? And that's kind of the explicit purpose, is to turn it off.
Yeah. So more often than not, an epidural comes with Pitocin. And then that's because of that. So they give you an epidural to deal with the pain, and then they do Pitocin after a little bit of time, because the epidural slowed down your contractions.
So maybe in my friend's case, she didn't get the Pitocin because she sat there for hours, and she ended up having a cesarean.
Oh.
Yeah. She didn't want to have a cesarean. She wanted to keep it going.
Yeah. Did they try Pitocin?
I don't know.
I'll have to ask her, because it's hard to know, because there are times when babies tolerate natural contractions just fine, but they don't tolerate Pitocin well. And so this is something I guess I wish more people knew, is that an epidural almost always comes with Pitocin, because an epidural is very safe for baby. It's not going into baby's bloodstream. Because the medicine is delivered directly to the spinal cord, we're not delivering it to baby's bloodstream. So I think that's very appealing to a lot of women, because they're great, I don't have to worry about the baby. But we are delivering the Pitocin, and that is affecting the baby.
Yes.
And because it's going to change the way your body contracts.
And Pitocin is IV?
Yeah. And so some babies don't tolerate Pitocin contractions well. So I wonder if that might have been what was happening. So if that happened, if they gave her a really strong epidural and it kind of shut everything down, if they tried Pitocin, which I don't know, usually in town they almost always do try Pitocin, but if baby starts to have decels in their heart rate or starts to show signs of stress, then they take off the Pitocin. Rightfully so, right? Sure. But now we're kind of don't have as many options. And so when we could be creative and come up with other options, I found out at Skyridge they're using Dilapans, which are these little silicone rods that you stick in the cervix, and they attach water. They're hydrolytic, and they like attract water and swell and like manually dilate the cervix. Oh, exactly. Oh. And so I'm like, we could do things like that, you know, if before we use Pitocin even, or if Pitocin's not working, or, you know. But I don't find that we do a lot of things here. We have like our one tool, and if that doesn't work, we're kind of, yeah. So they might have turned it off because the baby had distress. I'm just speculating. I have no idea.
Yeah. I mean, I don't know either. The way my memory is on her telling me that story is that they gave her an epidural, everything stopped. A couple hours later, they were like, we're tired of waiting. We're just gonna, open you up.
That's sad.
And that's a very sad story.
Yeah.
I mean, the kid is super healthy, beautiful,
Good.
Amazing, beautiful kiddo.
Yeah.
But yeah, so I was definitely curious about your opinion on that.
Yeah, I mean, it definitely could happen that way.
It could happen that way.
Yeah, for sure.
So, okay, so it sounds like you're not against epidurals. It sounds like it's an okay tool to use.
Yeah.
Okay.
I think epidurals can be really helpful, especially like with somebody who's really exhausted, or we've been laboring more than one night. So say we're like going into that second night and she hasn't really had any sleep. Some women have a hard time resting the first night of labor. So even if it's mild, they just feel like all that anxiety, all that adrenaline, and they just cannot rest. And so they're trying to like push and push and push, or you're just anxious, and they can't let it go, or maybe their labor starts and they have harder contractions. They're not having mild early labor. And so once we run into that second night, well, it's really hard to push through that. Like, you're very exhausted. And so we can get to a point in labor if we're like trying to do this naturally, but maybe don't have the reserves that we need, where we stop making progress. And I've seen that happen several times. And so we're having regular strong contractions, then they're getting stronger, longer, closer together, but we do this for several hours, and because she's so tired, we're not actually dilating more.
Whoa.
Yeah, we get stuck at 7 for like 6 hours.
Whoa. And then an epidural would be indicated in that?
I mean, it's up to the mom. So at that point, I would probably suggest that we go in and get an epidural and take a nap and wake up when you're complete and push the baby out.
I see.
At 7, we're kind of in transition. Even with an epidural, your labor's probably not going to stop. We're far enough along. And because your labor started naturally and we've gotten this far, like, even if we need Pitocin, it's usually, we say it's just a whiff of pit. It's like a very small dose. Or like just a whiff of pit. Like just a little bit.
That's so funny.
And it's like on 2 or 4, and that's enough to have them contracting regularly again.
I see.
And they can take a nap and chill and then wake up and deal with their baby.
I see.
Yeah, epidurals are fantastic in that scenario.
Uh-huh.
Yeah.
Okay. All right, cool.
Yeah.
Fascinating. Okay, let me see what else I want to ask you about. Okay, what are some, is this a good question anymore? Yeah, I guess it's still a good question. What are some typical challenges or obstacles? What are some typical challenges or obstacles during birthing process that you see?
Like, for me, for the birthing person?
For everybody.
For everybody.
For anybody. I don't know.
Like,
is there something that comes to mind?
What obstacles might we deal with? I'm like, that's a great question. I feel like the biggest obstacle is like surrendering. It's very difficult in our culture. We don't have a lot of things that are like birth. It's like we've forgotten how to be human on some level. Mm-hmm. Does that make sense? Yes. And so it's very hard to like talk people into like trusting the process, surrendering to what's happening, like knowing you can like trust your body, like you can trust this process, like we're gonna walk with this as long as we can until something is like wrong, until something shows us like we need to help this. We don't really do that in any sphere. Yeah. We like to like manage and control and program and plan, and like I'm guilty of that too, totally. You know, and I just think that birth reminds me over and over, you can't do that with this. This is just it's like built into the system. Like you don't get to control it. And that's really frustrating. Like for me too. And I think this is why we are where we are with like modern medicine. If a doctor does a cesarean section, they are not going to be sued for that, because we say healthy mom, healthy baby. But is she healthy? Like, is mom okay? Like, did she have really consent to this procedure? You know, is her body ever going to feel like it's hers again? Like, we've just like dissected this process instead of like have this holistic process. It's like changed so much, and we don't have community. We don't have, it's just like, it's very different from how things are meant to be. But then I think sometimes going back to how things are meant to be is also challenging.
It is challenging because you know better than I do that before, like back in the day, death for either mom or baby during the birthing process was kind of common.
Right, yeah.
So, like, on some level, you know, someone might be able to argue, oh, no, it's better to have all of these But also, I think you still have a good point that accepting and surrendering and realizing that it is built in, your body is meant to be able to do this from the very beginning, you know, that's how else are we supposed to get here? So I don't know. Yeah. What do you think about that? Sort of, there's a tension between those two ideas. So I don't know. What do you think about that?
I mean, I'm grateful that we have modern medicine when it's needed. I think it's just kind of gets overused, and I think that's natural as far as like when we have something, we've built all these systems and we have all these staff and now we need to use it all the time. Does that make sense? So that's kind of like a driving force in the whole thing, instead of just having it as like a backup system. Like the World Health Organization estimates about 10 to 15% of women, this is all women, you know, every patient would need a cesarean. So that's like from the very highest risk patients to the people that I'm seeing. So, you know, so that's kind of like gives you an idea. In the US, we have places where it's as high as 50%. 50% of women are having surgery to give birth to their babies. So
seems high.
It's so high.
That seems high.
Yeah, and Colorado is better than most. Like Colorado hangs out around 25%, which is pretty reasonable.
That's cool.
We have this expectation of everyone's going to give birth by 39 weeks. Well, that's crazy. Like,
yeah, no.
like,
no.
What? And so, but I think there's a lot of fear, and there's a lot of like what you're talking about. I don't want to die. I don't want my baby to die. Absolutely. Nobody does. Like, of course, you know, of course. And, you know, it's hard because like how many cesareans makes it worth that? Does it make sense? Like, how many cesareans do we do to save a baby? You know, because we're probably doing hundreds to save like one baby, you know?
I see. Yeah.
And
Use
so
and overuse are very different things.
Exactly. And so we're missing out, like your friend is missing out, like the baby's healthy, but at birth, the baby's microbiome is being seeded. So that baby's microbiome was not seeded at birth. So what kind of long-term implications for that child's health exist? Not to mention if mom goes on to have more kids, the risk to her future babies, the risk to her. I mean, yeah. So it's like, there's not an answer that is like without pros and cons. And I think that that's sometimes what we lose in the medical model, is like an understanding of like, this might be the best this best decision for this situation, but it might not be. And this decision belongs to the patient. This isn't my decision.
Yeah.
This is their decision. And that's the hallmark of midwifery care. It's like informed consent. It's like, there's never a bad reason. There's not necessarily a bad decision, just like a bad time for that decision, if that makes sense.
and a weighing of the pros and cons.
Yeah.
And a weighing of the pros and cons. So for someone who, let's say in the scenario that there's a justified cesarean, in that scenario, do you have any recommendations on things that you can do to like support even further? Like, I don't know, maybe take a vaginal swab and wipe and squeeze the head or something, or like...
Yeah. I mean, vaginal seeding is a thing, to like, take swabs from the vagina and wipe it on baby's like mouth and nose and eyes.
eyes, nose, and mouth.
Yeah, but
and I feel like I would want to squeeze their head a little bit. Is that just my
You're
imagination?
So cute because they get squeezed when they come out.
They get squeezed.
Yeah,
I don't know.
I don't know. I mean, that makes sense as a chiropractor that you're thinking about that. You're like, I'm pretty sure his skull needs squeezed.
I just gotta give it a little hug, just right? I don't know.
Yeah. I mean, body work is always a good idea. So they're still getting squeezed out of a small hole, if that makes you feel better. Usually cesareans are pretty small, and they are still getting squeezed outside of a small hole.
I see.
But yeah.
I see.
Yeah, I mean, asking them to keep the cord attached for a while. Asking them keep the cord attached and go ahead and deliver the placenta and keep the cord attached.
That's an all case scenario though.
Yeah,
right?
But they don't do it during cesareans. They clamp and cut the cord. They'll wait 60 seconds here. They deliver the baby, wait 60 seconds, clamp and cut the cord, and then deliver the placenta.
Oh.
I know.
Why?
Because that's kind of how they do it. And so they're thinking that if they want to wait longer, they have this like woman open and bleeding. Does that make sense?
Oh, okay.
But I'm like, go ahead and deliver the placenta.
I see.
And leave it attached to the baby. It's still
gonna leave it attached.
Yeah, it's still gonna do what it needs to do.
Right.
Like it doesn't need to be attached to her. Just leave it attached to the baby.
Yeah.
So I don't know.
That sounds reasonable to me.
It's more just like this is how they do it. They've been trained. This is a very specific process. Surgery is a very specific process. So
I see. And I've heard to leave cord attached until it goes white.
Yeah.
Is that a good rule of thumb?
For sure.
That's your rule of thumb. Okay.
Mom taking probiotics during pregnancy, during third trimester can help. Feed the baby like only from your breast. So like don't let them give the baby bottles or sugar water or pacifiers or anything else in the hospital. Like try to latch the baby in recovery. Tell your partner, if I need to have a cesarean, please help the baby latch like in recovery. That's the hard thing about cesareans. Is one of the hard things is that your baby's going to be awake for a couple hours after birth. So they're pretty alert the first 2 hours. After that, they're going to be very sleepy. And it takes about 2 hours for mom to come out of that surgery, to be like totally cognizant. I know they don't put moms under, but she has a lot of meds. So they have a lot of anti-anxiety medications. They have like a lot of meds, and then they have to sew her back up. And a cesarean is like, I don't remember, 6 layers of the body. It's
depending on how you count, it's a lot of layers.
It's a lot of layers. So just stitching her back up is going to take a while, and then they're going to take her to recovery. And this is assuming she doesn't bleed too much and she doesn't have any other complications of surgery. I mean, major abdominal surgery, and now you have a newborn. That's hard, you know.
Yes.
Women can collect colostrum before the baby comes, like just in case. They have on Amazon little colostrum collectors, like these little tubes, and can freeze it. Then if you're not able to feed baby right away, you could give them some of your colostrum.
Nice.
Yeah.
Nice.
Colostrum has, it's very high in protein, but it also has prebiotics in it. So it has food for your baby's gut microbiome. So the bacteria in the baby's stomach eat the food in the colostrum. Does that make sense?
It does make sense.
Crazy.
Yeah.
So like, it's just wild. So yeah.
And that's all built in right into the system from the beginning. It's a miracle.
Exactly. Like when we mess with nature, we get more than we bargain for. Because we only know so much about the process. We're always learning more. We didn't even know this about the microbiome 10 years ago. We didn't know that it was seeded at birth. We didn't know that that was really important. You know, and now we know it's linked to autoimmune disorders. It's linked to asthma. It's linked to, you know,
all kinds of stuff.
Mental health. It's linked to, you know. So there's just so many things that we didn't know before, and that's why, I mean, we used to give them like cow's milk mixed with Sprite if we couldn't breastfeed.
What?
Yeah. Like,
really?
Yeah, back in like the 1970s.
You're not making that up?
No.
That sounds like you're making that up.
No, they would put cow's milk and Sprite to help with that digestion.
Cow's milk and Sprite?
Or cow's milk with Cairo syrup. That's another one I heard. Some Cairo syrup mixed in. Because that's all we knew. We knew we needed milk and we needed sugar because we know breast milk's a little sweeter. So that's what I mean is like we're kind of like trying to reduce things to the sum of its parts.
Yes.
Formula, so now we dissect breast milk and we like try to remake it with like other things, and It's not the same thing.
No, it's not the same thing.
Yeah.
It's definitely not the same thing.
Yeah.
No matter how much you want it to be the same thing, there's a subtlety and a nuance to nature's chemistry that there's no way that we're going to be able to replicate it.
Exactly. And breast milk is constantly changing depending on the baby, depending on the stage of their life, depending on whether you're getting sick or they're getting sick, like all those things.
Yes.
Somebody just asked me the other day, when is the child's immune system strong? Like kind of considered mature. And I was like,
it's an interesting question.
That's what I said. I was like, that's an interesting question. I was like, technically, our like ability to produce antibodies is pretty mature at 2 years old, is from what I've heard. Before that, we're not really effectively producing antibodies. I was like, but in some ways, your baby's immune system is stronger now on breast milk than it will be at 2 years old, because their mom is like testing all the germs out there and making antibodies and giving it directly to the baby. That's a better system for avoiding illness than what the baby will have at 2 years old. Because I guess what he was trying to ask was like, can the baby be around people? But I didn't know that was where we were going at first.
I see. It seems to me that the answer would be yes. Baby is okay to be around people.
Yeah. I said, use your discretion, like have them wash their hands, but it's fine.
Sure.
Yeah, I was like, again, the baby is very protected right now.
Yeah, maybe don't have a sick person cough on the baby's face.
Right, exactly. But honestly, the baby's probably not going to get sick. You guys might get sick, but this baby who's nursing around the clock, they're probably not going to get sick. They're going to get so many antibodies.
Yeah.
And this is, again, a full-time healthy infant who's gaining weight, who's,
right.
Has a functioning,
right,
system with its mom.
Right.
Yeah.
Yeah, okay.
Yeah.
Okay, cool. Oh, this is amazing. Okay. Okay. So what's something that you find yourself regularly educating parents? Like something that what's something that you find yourself regularly educating parents about during your involvement with them?
I'm like all kinds of things. Excuse me.
Maybe top 2, top 3.
Yeah, I know. I mean, really just about birth. I like to go over like the ins and outs of birth. Like the mechanics of birth.
So like how, so what do you mean? So give it to me. What?
I have images. I'm like, I can't do it without my images.
Oh, I see. You
I have
pictures.
I have big pictures from the 1980s.
like anatomical sort of education?
Yeah,
okay.
Yeah, exactly. Okay. So I teach a free class at the library like once a quarter and go over. Yeah.
Oh, I want to go.
Yeah, you can totally go. I'll send you the information.
Please do.
Yeah. And so, and they actually have a great postpartum one too, if you're interested in it. Amanda Baker from Mindful Springs does the postpartum stuff. So I do the birth plans and postpartum with other people. Okay. So, but yeah, I have kind of like anatomy. I like to talk about the different ways of making progress in labor. I like to talk about how labor is like the long game. It's a marathon, not a sprint. We have this idea in our culture. So a lot of times I'm trying to dismantle how we think about birth. Like people are like, labor can start without my water breaking. Yes. The water only breaks early 10% of the time. Oh. Usually, that means 90% of the time, water's breaking sometime during the labor process. Most often at the beginning of like second stage. So we've already done 1 to 10 centimeters. Now it breaks. Oh. Usually when baby starts to kind of rotate and enter the birth canal, increases pressure on the back. Now it breaks. Oh. So, yeah.
I didn't know that.
Yeah, see? Okay. So just kind of like talking about how birth works. So there's like the 7 cardinal movements of labor. I don't know if I can like name them. It's like naming the 7 dwarfs. I only get like 4 of them. So, but basically the baby's coming down and like rotating through the pelvis. So, and they're helping you they're helping you come out. So they're helping you give birth to themselves, I guess. But there's different ways to make progress. So we talk about dilation all the time, right? Like you've probably heard like she's 7 centimeters or she's 4 centimeters or whatever. And you think, okay, yeah, I know we need to get to 10, right?
10
like I know 10 is the magic number, right? There's a lot of, I guess misunderstandings of that. It's not so much like we're not going in there with a measuring tape and like saying like looking for 10 centimeters, right? It's more of like has the cervix completely like gotten out of the way of the baby. So it's about the cervix withdrawing, yes, moving up, and it's about the baby coming down. So that's why there's oftentimes a kind of a stall, or it seems like there's a stall between like 5 and 7 centimeters. That's because before 5, we're actually measuring. Like we're actually measuring how big is the opening. But after 5, we're measuring what's left of the cervix. Oh. Does that make sense?
It does make sense.
Because we're not going to go in and like be like try to stretch 10 centimeters. That's silly. So we're going in to see where are we at. And the cervix dilates like an ellipse. So it's not going to dilate like a perfect circle. It's going to dilate like...
It's like an oval.
Like an oval, exactly. And that back part and those sides are going to be gone first. The last part is going to be up front in front of the puke bone. And that's because of like how baby navigates the pelvis. It's because of how your uterus sits in your body. It's because squeezing past that puke bone is a little harder because it has like the baby's hard head there and then the puke bone. So you kind of have bone against bone. And so your body's trying to pull that up. When your body is like progressing, it's not so much that the cervix is opening, that it is that the uterus is pulling up. So the uterus is like a big, big muscle in the body by this point. Usually it's very small. But by this point, when we're 40 weeks pregnant, it's very big. And so it's pulling. And it wants to make the top or the fundus thick. And then that thick fundus is going to be what ejects the baby. So it's building all of this muscle at the top to eject the baby. Mm-hmm. Does that make sense?
It does.
And so there's effacement. So effacement means like the cervix is thinning. So in a normal like woman at term, her cervix is going to be 3 to 5 centimeters thick. So it's about this thick, right? So I'm like, every woman's different. So when we're giving a number, we're guessing. Like I'm not, I didn't write it in your chart. Your cervix is 5.5 centimeters. I don't know. I'm just guessing. Like it feels like it's smaller than it probably was. I mean, that's the thing. And that's why you can get different numbers with different providers. If somebody checks you and then somebody checks you an hour later and says you're 5 when you were 6, it's all the same thing. It's just like provider's discretion. Like you didn't undilate, not usually, but that's a whole nother shit. That can't happen. I know. So one way we make progress is effacement. And if it's your first birth and you have never had a baby before, then your body's usually going to thin out that cervix before you start really dilating. And you can imagine, I don't know if you've ever seen that balloon trick. They put like a ball in a balloon and they squeeze the top. Or it's like pulling a turtleneck over your head, right? As the turtleneck comes over your head, that neck of the turtleneck is getting smaller and smaller.
Yes.
So it's like that. So that's great progress. Like sometimes you can be 1, but you've been doing this for 8 hours, and that's because you're also 100% effaced. So it makes sense. So the early part of labor can be quite long, but...
Okay, so we have effacement as one number and dilation as a separate number. Is
exactly,
I have that right?
Yeah, okay. And there's a third number.
Oh.
So it's like, which would be station, or like where is the baby in the pelvis related to the ischial spines. Thankfully, like bones. So.
Yes.
So we're not really checking for ischial spines. It's very uncomfortable. I don't know if you've ever checked somebody for their ischial spines, but it kind of zings you. So we don't really do a vaginal exam and check for ischial spines. Why would you do that? Like, it's not very nice. So again, we're guessing. Like, where does it seem like it is? But once baby's basically +2, we've hit the pelvic floor. So now baby's kind of hitting that sacrum. So now we're kind of we're really in there, and that's usually when we're starting to push. So sometimes one of these numbers is changing, but another number is not changing, but we still need to look at the whole picture as this is progress, because we're progressing towards the baby coming out. Does that make sense?
It does. It makes perfect sense.
Yeah.
This is cool. I'm both happy and sad that the more I learn about this world of pregnancy, I'm like, I thought I knew something about this. And then I realize how little teeny tiny. I feel like I barely know anything.
So what did you know about birth?
Oh, well, so
where did you get your information?
Yeah, so in chiropractic school, there's a part of our program that's core curriculum. Everybody has to take what we call adjusting special populations.
Okay.
So special populations means pregnant mothers,
Yeah.
babies, and the elderly. That's what is meant in this context by special populations. So it's an 11-week course, and it's just very, very simple stuff. We learn a little bit about the process, but mostly we learn about like how to modify our adjusting techniques.
Okay.
So that's core curriculum. Everyone has to go through that, at least at the school that I went to, which is Life University in Atlanta, Georgia.
That's great.
And then on top of that, it's something that I care a lot about. I have a big passion for some reason. And so I took a seminar series outside of the core curriculum.
Yeah.
That was a 14 weekends worth of education.
Okay.
And we learned all kinds of stuff during these 14 weekends. And so that's where I got the sense from that I thought I knew something.
Yeah.
Because 14 weekends, you'd think you'd learn something, you know?
Yeah.
But it turns out that, 14 weekends is like just dipping my toe in the water is what it feels like when I talk to someone like you, or when I talk to someone like John Davis, who is...
I was going to say, I was like, Dr. Davis kind of knows a lot about birth.
He knows a lot.
That's because his wife had home births. So don't let him take all the credit. That's because he's walked with Jamie through several births where he was there and involved, right?
And also, his education when he was in school was different because I think he specifically sought out mentors during his time there that were like top of the top, best of the best, maybe even in the world, and he studied directly underneath them.
Okay.
So, and I didn't have that quality of mentorship when I was in school.
Yeah.
So Jamie was a big source of learning for him, I'm sure.
Yeah.
And also a lot of credit has to go to his mentors, and so
for sure.
like all that kind of stuff. So yeah. When I talk to someone like him or someone like you, I'm like, oh God, I don't know anything. But that's why I want to have this conversation.
Well, it's complicated, and we're always learning new things. I'm always getting questions, and I'm like, oh, like I have no idea. Like, let me go look into that. Like, I don't know. So there's always new things coming up in pregnancy.
Things. Always more to learn.
Yeah.
And that's why I love this kind of stuff, because this is, like I said at the beginning, this is an opportunity for me to learn, and then I get to share it with people, and so why not? So that's why I like this. Okay. Okay, you mentioned, did you call it Bradley technique, Bradley method?
Yeah.
Okay. So are there any, what other methods, what other techniques?
Yeah, I mean, I think hypnobabies is great. Hypnobirthing.
Yes.
And that's what it sounds like. It's like self-hypnosis, using it for like the challenges of labor, in order to kind of like mind over body.
So you're a fan of hypnobabies?
Yeah.
Cool. I've heard only good things about hypnobabies and hypnobirthing.
Yeah.
So that's cool that you are in agreement with that.
Yeah.
That's something that every mom, no matter what, all moms should learn about some level of hypnobaby kind of, like, could we say like that? Or could it benefit all mamas?
It could. I think it could benefit all moms, but that's different than saying every mom should learn this. I think people should learn what resonates with them and what, like, veer to what they think would be helpful to prepare them for birth. Like, I think it's all moms should prepare themselves for birth. I do think it's like something that is different than anything we normally do in life. So I think it takes some preparation, but I don't think there's like one only method.
Nice.
And I did kind of, with my second birth, because I told you it was so fast, I couldn't do Bradley method. I couldn't lay on my left side and not move and sink into the mattress. I wasn't doing any of that. I tried it for like 1 or 2 contractions, and I was like, oh, fuck that. Like, I
doesn't feel right.
Cannot do this. Yeah. And so then I kind of felt like I was doing it wrong. And then I kind of was like thinking later, like I was sorry that I had put that weight on myself.
Nice.
And so now if I tell somebody like, hey, this is a Bradley book, love Bradley method, works for a lot of people, don't feel like you have to be still during contractions. You can do this method and still move if you need to move.
Yeah. Tools in the tool belt rather than hard and fast rules.
Exactly. And so, that one seems very restrictive, and how Dr. Bradley talked about it, the book that kind of breaks it down, is not quite as restrictive. So,
Cool.
Yeah.
Nice. Okay.
It's a great position. The position they want you to use is a great position for birth. So, it's just kind of, just having grace with yourself that in the moment, you don't know what's going to help you deal with contractions.
Yes.
Like, who knows how you're going to feel about it,
Yes.
So what worked the first time might not work the second time. What worked the second time might not work the third time. Like, that's just birth. Like, we don't know. It depends. Where is baby? How are they coming down? How big is the baby? Like, all of those things make it feel different.
Yes. Cool.
Yeah.
Okay, so any other techniques that you're a fan of that you think would be good to have as the tools in the tool belt?
I love spinning babies, so it's not quite as much of like a technique to cope with contractions as much as it is like how we can encourage like optimal positioning even during pregnancy. So I'm like, that's like a
spinning babies.
Yeah, spinning babies. So they have an online website, and then they have tons of free content on their website. They also have like parent classes and all that stuff too, but they have a lot of free content. And basically we kind of want baby to like start labor on the left side towards the front. A lot of times how the ligaments and the body works is that it's going to try to rotate baby this way. So if we start on the right, sometimes we're going to rotate baby all the way around, or we're going to rotate baby to the posterior, and the baby's going to try to come that way. And that's much harder. It's much harder to push a baby out if they're facing upwards. Yeah.
Okay, cool. Any resources that you're not a fan of?
Oh, yeah, for sure.
I've heard What to Expect When You're Expecting is
the
worst book of all time.
Yeah.
Okay,
it's
cool.
Very, it's very fear-driven, and it's very, this is the test that's coming next, and these are all the things that could be wrong at 20 weeks of pregnancy. And I'm like, whew, that's a lot. Like, I don't know. I'm like, I don't think it has enough helpful information to balance it. I love Aviva Romm. So she has a book, the Natural Pregnancy book, I think. She's fantastic. So she's an MD, but she was a midwife before she was an MD. So she has kind of both worlds. And I love her content. She breaks things down. She has a lot of like natural options, and a lot of just good information.
Aviva Romm?
Aviva Romm.
Aviva Romm.
Yeah, ROMM.
ROMM.
Yeah,
okay.
Love her. So
cool.
What were you asking me? Oh, what I don't like. Oh, I'm like, there are some schools of thought traveling around now that are getting more and more popular about like how any kind of support during your birth is an intervention and should be avoided. Does that make sense?
That sounds weird.
Yeah, and so I have beef with that because I'm like, that's all well and good if everything is fine. We know that unassisted births have higher death rates. Like, we know that the stats are not good. We know that births attended by midwives have great statistics. We know that maternal and infant mortality is usually lower than higher intervention births. So, but we know that's not true for unassisted births. So while I can understand how the spiritual aspect will be changed when you bring in like an outside person to kind of guide you, I just don't feel like it's worth the risk. But of course, I mean, I'm biased. I mean, it's like...
Well, sure. But also, I mean, even, this is maybe a very crude analogy, but even the best sports athletes have a coaching staff.
Yeah.
Like, Michael Jordan had a coach.
Right, yeah.
And he relied on that coach. I don't know, it's a crude analogy, but...
There are things that can happen during birth that would be very hard for a woman to deal with on her own.
Yes.
Like shoulder dystocia. Like, some babies get stuck and they need help out. Like,
why would you not want to have an expert to help you?
Literally.
Yeah.
So, and it's like, I don't mind being very hands-off, like you want to catch your baby, you want your husband to catch the baby, just like I want to be there just in case.
Yes.
That's why you have a midwife, just in case. Like, most of the time birth happens even if nobody's around. Great. But what if something happens? Like, I don't know. Do you want your partner to be taking care of your other children while they try to stop your hemorrhage? Like, does that feel like more spiritual, less traumatic? Like, I don't know. I have beef with that. And there's there's things I have to unfollow them because I get mad and I don't want to go on and start a fight on Instagram or Facebook. So I just back out of it. But I've seen things that are very hard lined and they call it like free birthing. There's a big free birth movement. And while I can appreciate some of the parts of free birthing, like I said, like personal autonomy or like wanting to have a holistic experience, totally understand that. But like find somebody that can be there for your just in cases, please.
Yes. That sounds like an extreme reaction to the extremeness that Western medicine wants to control everything too hard. This seems like an overreaction to that.
Yeah, for sure.
Right.
And also, if it's your first baby, you're going to have to push it out. So some people say, breathe your baby out. You don't have to push. Your body will take over. Just keep breathing. Breathe your baby out. I'm like,
You got to push a little bit.
You're going to have to push it out.
Yeah.
And honestly, your body naturally holds its breath when you push. So if you bear down, like with all your might, like you're trying to push a watermelon out of your butt, like this is so big, guys, like you're going to naturally hold your breath when you bear down. So it's actually counterintuitive to breathe when you're having an urge to push. I don't tell women, hold your breath. They do hold
it
breath.
on their own.
Yes, unless they've been reading and heard, breathe your baby out, breathe your baby out, breathe your baby out. If you've had a couple babies, fine, breathe your baby out. It's totally going to fall out.
That sounds like maybe more of a metaphorical cue than like a literal
I
cue.
think it's like a pushback against like the purple face pushing or hold breath pushing that they do in the hospital, where they're like counting to 10 and they're like 1, 2, 3, and they're like everyone's holding your legs and your face is all purple and it's like we're trying to push back on that, which that's great. Yeah, that's
great.
Yeah, let's push back on that. This is not making women feel empowered to be like manipulated and held and let's push back on that. But also, if it's your first baby, like prepare your mind mentally to bear down some.
Yeah, again, that seems like an overreaction. That seems like an overcorrection. Like, it's better to be in the middle ground on these things rather than having to be extreme one or the other.
Yeah,
right?
Exactly.
Yeah.
For sure, yeah. So, I mean, other than that, no. I mean...
Cool.
Take what works for you, and if you have a whole program and you get 50% of it and you like that 50%, then great.
Yeah.
Yeah.
It very much makes sense to me to have someone who is very good with a lot of experience during these experiences, to be on your team, and for them to be good listeners and for you to be a good talker to say, okay, I want this, I want more freedom here, I want more assistance here, and then you can sort of like have that dance, instead of like, no one is allowed except for me and my partner. I don't know.
Historically, women were not birthing alone.
Yeah.
That's not more traditional. That's not, I don't know.
Right.
That's not more holistic in my opinion. It's just kind of,
right.
I don't know where it comes from exactly, but I've seen some things and I was like, oh, dang.
Yeah. No,
but
I have this image in my mind of like a woman with like two other women in the tent.
Yeah. Right.
Kind of thing.
Exactly.
Like that's the traditional image that comes to my mind.
Yeah. Because it's hard to do anything else when you're in labor.
Yeah.
Like you might need someone to bring you water, to bring you a towel, to bring you,
Right.
And like, I don't know.
Right.
Some partners can be that person and some partners are not as much that person.
Yeah. Cool.
Yeah.
Okay, cool. That's great. Okay. Do you have okay, no, before I ask that question, I'm going to ask another question. What, other than midwife, is there anyone, other kinds of professionals who you would suggest to have on the team?
Yeah. I think a doula is great. Having a birth photographer can be really fun if you want to have images like that. Some doulas do childbirth education, but if not, it's good to go into childbirth education. Chiropractic care is amazing. Pelvic floor therapy is amazing. Sometimes prenatally, but especially postpartum. I'm like, who else? I mean, anybody that's needed. It just depends on what's going on with her pregnancy. Acupuncture we use on occasion.
Oh, that's cool.
Yeah, can help you get into labor, but also like pain during pregnancy. I'm trying to think who else. I'm like,
I never thought of acupuncture. That's a cool one. Where would they put needles?
I don't know.
Wherever they do.
Yeah, wherever they do. on a meridian.
Yeah.
I don't know much about Eastern medicine. But we've used it on occasion for sure. A therapist can be really helpful if we're processing past birth trauma, if we're dealing with upheaval in their life, that can be really helpful. Whatever you don't kind of process during your pregnancy, you're probably going to process during labor. And that really sucks. So having to process feelings during labor is just...
someone to talk to about that stuff.
Yeah.
Is what you're saying.
Yeah. The more you process in pregnancy, the better. Because it can definitely make labor stall and slow down. And we need to feel like safe. If you think about like a cat when they're ready to like give birth, they're gonna like wait until everything's quiet and calm, and they're gonna go find their own little spot to give birth. They need to feel like safe and totally at ease before we can like release and go into labor.
Nice.
Mm-hmm. Yeah.
Nice.
It's a sphincter, right? Ida Mae Gaskin talks about that a lot. It's sphincter law. So you're not pooping in the middle of a room full of people. You're not giving birth in the middle of a room full of people either.
Right.
It's a sphincter. We're not controlling it.
Yes.
Yeah.
Yes. I remember John Davis was just telling me a story last week, and he was saying that he walked into he was requested to come into a birth one time, and he said there was like 30 people in the room. There's like aunt and uncle and sister and this person and that person. And he said, everybody out.
Yeah.
Everybody was like, no, everybody out.
Here?
Yeah, this is not a party,
It's not a participant sport.
Yeah.
That's what we say. This is not hockey. This isn't, soccer. Like, this is not a participant sport. Like, we need to have some privacy.
Yes.
Yeah. And I was at a birth a very long time ago with my preceptor, and she, they were from Australia. And she had a lot of friends. They worked with like youth group and different things. This was, I think, her second birth. And she invited everybody she knew because she wanted them to know that birth was normal and it wasn't scary and like things, this doesn't have to look scary. And then she like wouldn't go into active labor. She was like in labor and she just got stuck right there. Like every 5 minutes having like a pretty moderate contraction, and then we're not getting any like stronger, longer, closer together. We're just stuck here. And we were like, you might have to have your friends leave. This isn't gonna happen with everybody here. And so they all left.
Yeah, and then she had her baby.
Yeah. Then she went into like strong active labor, and then she let them come back, but they were all downstairs silent, like in a different part of the house. It's like, we can't.
Yeah. So maybe not 0 people, but also maybe not 30 people.
100%.
You might want to be very careful about who you choose, and maybe I don't know, chiropractor comes to mind. Like maybe you do an adjustment, you do a little thing, and then they can leave. Yeah.
Well, and even a birth photographer, they don't need to be there until you're like about to push the baby out. What we really want pictures of is like when the baby's being born. So, and we're going to reach a point of like no return. So usually around like 7 or 8 centimeters, doesn't matter who's in the room.
Then it's happening.
Is happening. Exactly. We're kind of like past that point of no return. And in like 90% of the people, it doesn't matter. There's always going to be some people that are more sensitive that cannot labor if you're watching them.
Yeah, cool.
Yeah.
Okay.
Everyone should have a job. That's what I usually say. If they're there, they need a job. They don't need to sit in a chair clutching their pearls. Oh my.
No, that sounds like
it's not the right vibe.
Not the right vibe.
No.
Yeah. Okay.
Why are you doing that? Why did she do that? Oh, she threw up. Oh. I'm like, no. This is not a football game. This is not.
Yes.
Yeah.
Yeah. Cool. Okay. Are there? I hope this is a appropriate and okay question, but I'm wondering if you have any cool stories.
Sure. Yeah.
Do you have any cool stories like that? What comes to mind when I say cool stories? I don't even know what I'm looking for.
I guess I think the funny stories are like the best. So
give me a funny story. I love that.
Because I mean, there's always cool stories. That's like the fun part of I think working in the medical field. Period. It's like I have a friend who's an ER doc, and every time I see her, I'm like, can you tell me a story? Yes. Like, what did people get stuck up their ass today? I just it's like the best, right? It's like ER stories are just the best. Like you're just always shocked. Like what? no way. So, yeah, I mean, I don't think I have any stories that great, but I went to birth one time. It was like off of Union. This was quite a while ago. It's like they lived in this cute little house. There wasn't a lot of space. There was like a lot of animals. So it was very chaotic. We had the pool blown up. There wasn't, again, not a lot of space. We're all kind of like snuggled in there. I was with my preceptor, Dottie, and I think we might have had a third at the birth. I don't remember. And her husband was there. They had just gotten a new puppy because, you know, that's a great idea right before you have a newborn to get a puppy. The cat was like crawling on the tub. The tub had a leak. So we were airing it up with a very loud pump every like 10 minutes because the tub kept losing air. So it was a little chaotic. So the mom is in like rocking labor. So she is like going at it. She's like in the pool, makes her husband get in. So her husband's in the pool and they're like facing each other, you know, and she's just like, you know, very intense with him. Like I can't believe you got me into this, you know? And so she's just getting more and more and more intense. And this poor guy, he's like trying to support her. She's like, squeeze my hips. And so he's like doing all the things. But as she's having these contractions, she's like rocking her hips and he's trying to squeeze them. But he's like going, like sinking more and more like into the pool of water. So she is like above him and his like head is like just barely above the water, you know? So we're just kind of watching this poor guy, like he's gonna drown, like, you know? And she's basically like riding him through these contractions. And we were like, well, the baby gets out how the baby got in, I guess. And she birthed the baby right on top of him. And I just thought it was the best.
Wow.
I was like, you just never know.
All right.
Most of the dads don't really get in the pool.
Uh-huh.
Yeah.
I'd get in a pool.
Yeah,
that
sure.
Sounds like a good time.
Yeah. Usually it's not so exciting.
Uh-huh.
Usually it's a little more, you know, calm.
Yeah.
But I don't know.
I don't know. I just like imagine like holding onto her shoulders or something, or just like, you know, like having her like having her face away, and I don't know. I imagine
supporting.
Support. Yeah.
Yeah.
I don't
for
know.
Sure. Yeah.
Yeah. Okay. Wow, that's a fun story. Cool. Any other ones that come to mind?
One time I was at a birth and it was her second baby. This was like during COVID. So she only really chose to have a home birth because she had a little girl already and she really wanted to bring her kid to the prenatal appointments. So she couldn't, it was during COVID, right? So they wouldn't let her take anybody with her to her prenatal appointments, not even her partner, nobody, but especially not kids. So she kind of signed on with me because of that. And I was like, okay, that's fine. And we tried to talk about birth, but she didn't really seem to want to talk a lot about like what birth looks like, you know, how natural birth goes. And I kind of was like, well, I don't know if this is going to happen at home or not, which is fine. Like, whatever. She needs to do what she needs to do. So she had kind of like one false start. Her labor started and then kind of stopped. And that happened once or twice. And then she went into like active labor. I think she was around her due date, nothing special. Go to her birth. She is not like labor. She's like, this is the worst thing ever. She kind of has that like deer in the headlights look, like she's panicking a little. Mm-hmm. So I'm like trying to talk her down to it. She's only half listening to me. And I'm like, we'll see. So I'm like, let's get in the pool and see if that helps. So she gets in the pool and she's like, absolutely not. This is horrible. It's worse, right? So she's like, I need to go to the hospital. And I was like, okay. Like I tell people, look, if you ever want to go to the hospital, you tell me, I'm going to take you to the hospital. I'm not going to talk you out of going to the hospital. I think women have intuition, and I don't know if you're speaking out of fear or intuition. How do I know? So I was like, okay, no problem. So I think I asked her if I could check her before we left, because I was like, this baby's coming soon. It's a second baby. It's obviously going very quick. And she's like, yeah, she was 8 centimeters. I was like, okay, so we're going to have a baby soon. So we go outside. I never really ride with the moms in labor. We're not usually
transporting emergently. Usually I follow, but I was like, I'm going to ride with you. This baby is going to come out. And so they were like, okay. So her partner has a bright orange Camaro. Very nice car. Okay. And so we get in the back of the bright orange Camaro. She is kneeling on the back seat facing the back. And I put a Chucks under her. You know what a Chucks is? It's like a waterproof pad, kind of like a puppy pad, but like a little bigger.
Okay.
So I put that under her because I'm thinking, we're having a baby. And so we're flying Union. What is it with Union? So then we're flying down Union to Memorial Central. I'm like, oh shit, we're never gonna make it. So I'm like, we're like flying down. I'm like, I would much rather catch her baby at home than like in the car, right? Because I'm like, I don't have my equipment. I don't have meds. I don't have, like, I brought my Doppler with me, but that was really all I had. So maybe some gloves. So her water breaks. You know, her guy is like, oh my God, my car. And I'm like, yeah, dude.
That's what the pad is for.
Yeah, I'm like, don't kill me in this Camaro.
Yeah.
Right? And so we get to the hospital and I don't remember how we got up to the like third floor. We did get up to labor and delivery. And her baby is like crowning and she's like losing it, her mind. Like she's just screaming. The doctor's yelling at her. Of course she like wants an epidural. Like we can see the baby's head. And she's like, push your baby out.
Yeah.
And I mean, while I don't like anybody to be like forceful with women in labor, this woman was not at all trying to like keep it together. She was totally losing it. And then she did push her baby out. Baby was great, healthy, no problems. But it was just wild, right? And I asked her later, like, do you have any regrets about your birth? Like knowing now that the baby was about to come. And she's like, no. And I was like, okay. I think for her, she needed to exit the process. Does that make sense? She just needed to not participate in the process. She was like, I need to like get out of this situation. I can't actually stay with this and like try to work through this.
You mentioned before quite a while ago surrendering into the process. It sounds like she was not wanting to surrender into the process. Not even a little bit.
Yeah. So looking back, I'm like, I kind of wish I would have been like, it's too late to go in. I'm going to call the paramedics. Like, we're not going to make it just for my own safety. But it, you know, all's well that ends well. She had a cute little baby and we did all the postpartum care. And
there you go.
Yeah.
There you go.
It was a story. My husband always brings it up. He's
go.
Like, remember the Camaro?
The Camaro.
I'm like, yes.
Yeah. That is a story.
Yeah.
Very fun. Very fun. Okay. Last question.
Yeah.
And this is kind of broad. This is a broad question, and a lot of the whole conversation has kind of, in a way, answered this question, but I'm going to ask it explicitly.
Sure.
If I say, what advice would you have for a mama? What's like the first flash that comes to mind for like advice for pregnant mama?
I think just really like I would encourage you to like go out and educate yourself. Like really look into birth as a whole and the different philosophies of birth so that you are aware of kind of what resonates with you and what makes sense to you, and then find a provider that will support that. Yeah. And if that's hospital birth and get an epidural at 3 centimeters and you do that, then great. Literally. But if it's not, then feel like there's somebody out there that is going to see birth like you do. So like, don't just walk into it blindly and think somebody else is going to tell me how to do this. That doesn't work well with birth. And it creates a lot of trauma where women feel like their voice wasn't heard. They didn't have any autonomy. They didn't have any, like, what's that word? Like kind of like options or choice in the process. Like the woman should be the locus of control in the process, even if we're having surgery. This should be a conversation eye to eye with her. Hey, this is what's going on. I'm very concerned. I don't see any other way to do this. This is why I think it's necessary. That's an empowered cesarean birth, right? When she's like, okay, like I can understand and I'm okay with that at this point. That's different than feeling like I didn't know enough to ask questions.
Yeah.
I didn't know enough to know I had options.
Actual informed consent.
Yeah. And don't count on somebody to give it to you, because it depends on where you're at if you're going to get that or not.
Yeah.
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 And some women don't have the option to hire a midwife. Like, people pay me privately. That's expensive, you know? I had births of my own where I could not have afforded that way. Like, if my insurance wouldn't have covered any of it, I would have been in a bind, right? So we should be able to have an empowered experience no matter where we are. Like, your bodily autonomy doesn't stop when you get pregnant.
Yes.
Yeah, that's all.
Yes.
Yeah.
Beautiful.
Yeah.
Yeah, beautiful. Well, anything else you want to leave everybody with, or?
No.
Yeah. Cool. All right, cool. That feels really good for me. What a fascinating, just amazing conversation. I enjoyed this so much, I can't even tell you.
Good.
Thank you so much for coming over.
Thank you so much for having me.
And chatting with me.
Yeah.
Yeah, this is really, really incredible. I hope that other people benefit as much as I did today, because
for sure.
wow, really, I really mean it. Thank you, Jennifer.
Oh,
Thank you,
yeah,
thank
of
you, thank
course.
you.
Yeah.
Yeah, cool. All right. Okay, bye-bye, everybody.